Let me touch on something in the time we have left just for a moment. We've all been talking about iron management strategies. To me, that means mostly chelation. I've heard that word a few times. Lead me down that path a little bit. Who gets chelated? How do you do it? What are the risks of that?
So the problem with the human body is that it has no way of excreting excess amounts of iron. It accumulates and it stores. So if you went out at lunchtime and had 2 bags of potato chips, your sodium level will not go up very much because your kidneys will pee the extra sodium out. If you got transfused with red blood cells, the iron that goes in there stays in there and has to be helped to be excreted. Your body has to get assistance to excrete that iron because you lose very small amounts of iron on a daily basis through shedding of epithelium mostly. So once you get to the point where you are filling up your liver is the normal storage site for iron. And as you fill up your liver, that iron can then spill out and go to other organs, particularly the heart and the endocrine organs, and then can cause significant complications there. So you want to prevent that from happening. So typically, after about 1 year to 15 months of regular transfusions, we will start somebody on regular iron chelation.
How often is regular?
Daily.
Daily?
Yeah. The good thing is now we have oral chelators.
That's where I was
You can take it once a day in the morning or at night, and you just keep taking that every single day, and you can be kept in iron balance.
And just so that we get the mechanism nailed down once, you take the chelator, it grabs iron,
Yep.
holds onto it,
Yep.
and where does it go?
So it gets excreted. So the different chelators get excreted different places. So the 3 chelators, the injectable one that we talked about that's been around forever, most of that gets excreted in through the kidneys, and it comes out in your urine. So your urine looks like rust, essentially. It looks red because it's rusty. And then with the once-a-day chelator, it's about 80% of it comes out through your bile. So your liver metabolizes it, and then it gets excreted in your bile. And about 20% in your urine. And then the third chelator, it's about half and half.
You've all been alluding to cure, one way or another. To me, I think I hear you alluding to allogenic stem cell transplantation. Is that where you're going with that? Is that what I'm hearing?
Yes.
And tell me about that. How does it work? How successful is it? Who gets it?
Well, I mean, again, there's probably a little bit of center-to-center variance in this, but if we have, at our center, if we have a newly diagnosed thalassemia major patient, who's going to be transfusion dependent, and if they have a sibling who's a perfect match and doesn't have thalassemia themselves, so there's 1 chance in 4 that any one of your brothers or sisters by the same mother and father will be a match. We recommend bone marrow transplantation, usually after age 3 or maybe 2 or 3 when they're physically big enough to make it easy.
Very early.
Very early, as early as possible. Often this discussion may go on for a while because there are some risks, but frankly the technology of bone marrow transplant has improved dramatically. And that cures them of the disease.
Again, going back to the history, the first bone marrow transplantation was performed in 1981. And I remember fighting for this approach because the pediatrician expert on treating thalassemia with standard transfusion and chelation, they were totally against bone marrow transplantation. Because at the beginning we lost, frankly speaking, we lost many patients due to the approach of bone marrow transplantation because they had to undergo conditioning with an important chemotherapy, and that, so we had many patients who died unfortunately at the beginning. So there was really 2 kind of school. Those saying we have standardized a good treatment with transfusion and chelation. We are keeping our patient living longer, so why we have to expose? Then I have to say, and that was a huge contribution of the Italian group, Professor Lucarelli, who actually amended the conditioning treatment, and nowadays I should say that bone marrow transplantation is the only not approved because even gene therapy, but the only proved curative treatment.
All right, let me go through, because I know many of the clinicians watching this have the same questions I do. I see bone marrow transplant patients. Typically, they're for tumor patients in adults, all right, because I treat big people. And they look dreadful, and the process is dreadful. Is it that bad for kids getting this? Is it the same?
So there are several things to think about here. One, thalassemia is no longer a lethal disease.
Okay.
It's a very cumbersome disease. However, that cumbersome nature of the disease does impact quality of life quite significantly. And so if you have the availability of a cure, you should think about it very seriously. We recommend going to allogeneic stem cell transplant right now, at least I do, only if you have a matched sibling or matched related donor.
Okay.
Because the results from those kinds of transplants are now well in the 90% event-free survival and 97, 98%
What
overall
about
survival.
immunosuppressive therapy going forward after?
Yeah.
They get immune, so it's not quite the same as solid organ transplant where you have to be on lifelong immune
Right,
therapy.
that's what I was asking.
This is only about 6 months of immune suppression
Really?
after the transplant. And then you can come off of it because now you have a new immune system from your donor.
Well, I think I'd have to say that and I'm not a bone marrow transplanter, but the technology, actually I was with sibling transplants, the mortality is very, very low. It's obviously not zero, but I've had some heads of major programs say, gee, we haven't lost a patient and they can't remember when.
Really?
Yes.
So they do very well. And the ability to match, but what's also happened, 'cause all this technology has been going amazingly fast in the last decade. So they can now do tissue matching by DNA and get very accurate matching. And the data suggests that if you have a 10 out of 10 or better unrelated match, that the prognosis there is also very good. And so supposedly very similar to that of a sibling. And so in the last maybe 5 years, we've actually been referring patients for unrelated donor transplantation as well. And the outcomes there are reasonably good as well. But one of the problems, if you want to call it that, with thalassemia is there is risk to bone marrow transplant. And we have an alternative therapy which we know we can manage very well, which is transfusion and chelation. And so it's not unlike the tumor patients, you know, you're talking about, where if you don't treat them, they're not going to survive.
Yeah, we have
so
an option.
that means that these discussions with the family sometimes
They
go
get
on for a
complicated.
couple of
They get
years.
complicated.